I'm Dr. Ravi, Assistant Professor at Saifee Burhani University, and I welcome you all for the one-day international workshop on the kinetic control for the lower limb. So Dr. Rasha has joined us, and she is going to teach you about the kinetic control, what is the concept of kinetic control, and how we can put it into a rehab plan in future. Okay, thank you so much. Dr. Rasha.
So, good morning. Because I'm not as tall as Dr. So, okay. So, first of all, can everybody here listen clearly to the voice? Yeah, perfect. So thank you, Dr. Rafi. I want to express my pleasure to SBU University for hosting the Prime Physio. For me, it's my, I think, 6th visit to Karachi, but first time to the university, so I'm excited to be here. And actually, I can see here familiar faces who joined our Prime Physio activities and my activities in previous visits. So nice to have you. This is how it goes with Prime. Once you joined, you are a loyal participants to us. So, as Dr. Rafi introduced the kinetic control, it's something related to the rehab. So you can feel that it's something school about the movement health. All right? So we have different approaches in physical therapy. It's a manual therapy, pain neuroscience education, and movement therapy. So this is the focus of our session. Who I am? I'm Rasha Hossein, a doctor of physical therapy in sports injuries and rehab. I've been graduated since 15 years back from Karachi University. I'm practicing musculoskeletal and sports injuries practice in Egypt, where I have my also private clinic currently that I do my practice. As for my relationship to Prime Physio, it started, I think, 2013, which is 12 years back. Like all of you, joining an organization, exploring what's going on, because meanwhile, we wouldn't be able to have any source of professional learning, actually. So I think I was lucky to be among this experience. I would say like career shifting experience, because continuing development learning is, for me, is how I could be able to practice on patients, not just the university. So before I talk about my journey with kinetic control, I'd love to introduce Prime Physio. Prime Physio is an education institute. It was the pioneer that introduced continuing development learning education in Egypt and UK, founded by Dr. Mahmoud Saad, senior lecturer in Sheffield Hallam University. So this is how the idea started when Dr. Mahmoud Saad started to host all the international schools that physiotherapists need to upgrade their practice, including the McKinsey, including the Mulligan, including the kinetic control, the Maitland, so all the innovative approaches and contemporary approaches we need for practice. Thankfully, we managed to host through Prime Physio Education. These flags are where you can find our activities. We do teaching activities and courses in more than 18 countries now, so I think I need to update this slide because thank God we are more expanding last years. This is our website, and I will be leaving the code in the end so you can know more about us. We have 4 main offices. Prime Physio started in Egypt, main office also in UK, and Dubai 5 years back, and last one was in Istanbul, Turkey. However, we have different collaborations in different countries, including Burhani Physio in Pakistan, that I also want to extend my greetings, that it's the reason why we are be able to be seeing you guys. So this is all. The main organizers for us is Burhani Physio. We believe in holistic management, and we will hear this word. So that's also why you find our products are different between manual therapy courses. This is through our main program, the OMTA, or the Orthopedic Manual Therapy Academy. This is the baby product of Prime Physio, where we have the International Manual Therapy Certificate. And the OMTA is the interest group, international interest group in the IFONT, which is the International Federation of Manual Therapy. And also we have affiliates with the McKinsey Institute, because as I mentioned, Prime Physio is the first collab body that hosted the McKinsey, and we've been giving the official McKinsey courses in different countries. Also the Maitland, same for the POBAF, and also the Kinetic Control as a product of Comera Movement Sciences, that we first were hosting Kinetic Control courses, and later on we are now 17 of Prime Physio teaching officially the Kinetic Control courses, including myself. This list you can find our courses: clinical dry needling, neuro rehab, manual therapy, sports, dynamic cupping introduced by myself, Pilates in rehab, spinal manipulation. So all of the courses that serve the different schools of manual and movement therapy. There we go. So when I love to define myself, I'm more a clinician, like I'm coming more from the kitchen, more from the patient practice. Like 60 to 70% of my time I'm meeting patients, I'm treating patients, and 30 to 40% I'm teaching. So I define myself as a clinician first and a clinical tutor second. My career went like a double-faced career or double coin between teaching with Prime Physio, facilitating courses, shadowing all the mentors and all the experts that be able to come. As I told you, its journey started too early. So I've been exposed to all the experts and all the founders of schools, including the Mulligan. So we met Brian Mulligan, Stephen May, the author of the McKinsey book, Sarah Motrin, the co-author of the Kinetic Control, also was part of teaching me. So through my function with Prime Physio, I've been able to learn and be certified from all the concepts and the tools I use in my practice. So my patients are 50% sports, 50% musculoskeletal. The main highlights in my professional experience was in Gold's Egypt, because I worked for 6 years with athletes, either fitness coaches, elite sports like CrossFit athletes, and medical industry, not just the sports industry, through my working in German medical clinics and Dutch clinics. And finally, I founded my own clinic in the last couple of years. What's in it for you? That I will try to put my all, all the knowledge, all the experience with patients, and also to know that I will use like true patient stories to educate you to understand the concept based on what we actually do with the patients. Are you okay? Are you happy? So before I state the, this is why I'm here. So, okay, my kinetic control journey actually started 7 years back. In 2018, it was our Prime Physio first international conference, or it was the first OMTA Academy International courses where we hosted two big schools, the Brian Mulligan, the Mulligan Concept, and Sarah Mottram, the founder of Kinetic Control courses. So, or concept actually, with Marco Comerford. So when we talk about Kinetic Control, we know these two names are the founders of the Kinetic Control School. So at this conference, I attended a session, okay? And this session, 20-minute session, was a key for 7 years later. Why I got like excited into learning this school, because in this session, no diagnosis, no medical terminologies, it was just movements. So for me, it was very eye-opener. It was about shoulder and no shoulder impingement, no acromioclavicular arthritis, nothing. It's just talking about forces and movement and directions. So for me, I thought, tell me more about this. I need to know what these people are doing about this mindset of practice, you know? So, for you, the left, so you find my mentor, and Mahmoud San. Surely you are familiar with him because he is like our mentor and the one who already promoted me to the Kinetic Control. And Jacqueline Zewert, she's one of Prime Physio and the Kinetic Control senior tutors, and she was my examiner actually. And Sarah Mottram is right just at the side. She is, as I told you, the founder of the school. And Steve Spark in the down, because I'm interested in sports, so Steve Spark is also part of the Kinetic Control team in the United Kingdom. And he works with the Kinetic Control with the Manchester United team in the British League, because he is the official physiotherapist for Manchester United. And Dr. Fatma Bakri, you definitely, I think, all of you either know her or will know her, because she did a very big part of my journey, because she was our first one in Prime Physio team to take the lead for teaching Kinetic Control. And Dr. Hibatullah Ibrahim also, she is a women health specialist, so she applies Kinetic Control in women's health. Pablo Marino, Beata Sandet, so Cohen, I think, unless I missed him. Anyway, so simply it was big journey, was a lot of accumulated practice, shadowing and mentorship, and treating thousands of patients, because I think my credit so far is treating more than 18,000 sessions. I think this is an actual calculated numbers. So this is briefly who I am. Before I talk about the session objectives and the plan, I will stop here because I talked a lot actually. And I want to hear from you guys. Just give me heads up why you are here, although we are happy that you are here. But I want to know what you expect, what your interest about today's session. Anyone raise hand and make a start? Yeah?
For the assessment, lower limb assessment. Lower limb.
Assessment.
Yeah.
So you are more into assessment. Who else? Yeah? What's your good name? Yeah? So you want to explore more about the concept, all right? So anyone else want to tell me something he wants, she wants, he wants? I'm open to both. Anything? So let me ask you, because you don't ask, so I ask, all right? So what do you actually know about kinetic control? When I say the kinetic control, what's the thing that hits your brain?
Movement control.
It's related with movement testing actually. Anything else? And it's okay. It's not I'm not examining. I'm just exploring. It's movement, which is good a start. All right. So in this workshop, we will be talking about. We will understand the movement control impairments because we diagnose movement, we don't diagnose structures. We do diagnosis, but physiotherapy diagnosis is diagnosing function. And apply cognitive coordination testing, because you will understand it's a principle of kinetic control. And we will be designing targeted training according to patient. So the second thing to know about kinetic control, that it is patient tailored. It's not a protocol. It's a testing, training based on what the patient is telling me in the subjective examination. Everyone's okay? Also, we will be integrating this part into the other, like our main framework. As I told you, it's a combined package. So how to and when to integrate kinetic control in our musculoskeletal framework. So more about reasoning. What's kinetic control? It's a system, okay, that we use clinically. Because we have the challenge when it comes to assessment of muscle function or neuromuscular function, that we either need MRI or EMG, right? So the good news is Mike Comerford, Zara Motter, starting from 2002, started to make a graded system or rated system for the muscles, starting by classifying the muscles in our body and reflect this into testing to check what's wrong with these muscles, and based on the testing result or testing rating, how to turn the test into training exercise. And then according to patient. How? By comparing what we clinically see with the patient to EMG studies. That's why we know it's a reliable system and it is clinical system. Okay, so as I said, it aims to not just assess the pattern of movement, how the patient moves, and how this way of movement is the reason of the symptoms he complained today. Okay? So it's about movement pattern, movement way, faulty posture, but it's more organized. And the value of this concept, that the main goal and the main pitch, the main value of using kinetic control, or the aim of it, not just managing symptoms, but it helps recurrence. When we talk about the musculoskeletal problems, although the patients are coming complaining from pain, however, we know that the current pain is not the issue. You can treat your pain, the primary pain, by whatever the tool, starting from smiling at the patient. However, the always problem is with the recurrence. The patient gets better, however, few weeks, months, years, they are re-complaining again. We see the low back patient, and when we take the history, when it started, 3 years back, but it's on and off. This on and off, it means that there is something missing in the treatment. Interestingly, we have evidence that the patients or subjects complaining low back pain for the first time, they will be completely healed in the first 6 weeks, even if they didn't receive any treatment. Any person having a low back pain, first time to experience low back pain, whether he took medication, hot packs, he rests. We know that by research, by systematic reviews, that whoever is having this pain, he will totally recover in the first 6 weeks because of simply the body do auto-healing. Does it make sense? The body already has the ability and designed to heal itself by itself in a process called auto-healing, like the body self-heal. And based on this design of the body and the ability, If it's just the primary pain, the body can handle. But the problem is the patient again and again and again. And this is what the also systematic reviews confirmed, that 90% of the patient reported first episode, they will complain in the first year after the attack. And 80% of the patients complained in year 1, they will have multiple low back pain episodes from 3 to 8 attacks in 3 years. And this is what we actually, literally see with the patients. It started on and off 3 years, but the last attack was 1 month ago, when they finally decided to come to visit your clinic. Does it make sense? Good. So, long story short, what I want to say, we need a concept, we need a tool to handle the patient who is fed up with physiotherapy in different places because he is still complaining, to the extent that they believe that their problem is endless, that I will not improve more than this. Okay? So you can tell that if you started to modify the movement itself, the way these patients got injured, the symptoms and the outcomes go in different level. Are you okay so far? So kinetic control, it's a clinical system aiming to assess movement, diagnose movement, train movement, so patient can be engaged to function and not just pain relief. And the main focus is to prevent the recurrence. How? Because we will be working on the movement system, in the movement pattern, on the cause of how the patient got the symptoms. The cause, not the result. To the extent that this idea is used with athletes to even predict the injury before it's done. Okay? And we will know how. But this is the applications or the benefits of the kinetic control. Are we all okay? Good. How the kinetic control is developed. When we talk about physiotherapy history, at first, the idea was just treating the structures. Okay? Bone, muscle, tendon, neurodynamics. That was like an advanced step. So they started to have a gap that this is not enough. Okay? So we had another milestone, which is dealing with the muscle as a strengthening. If I strengthen my muscles, I will be better. And that was a new step. Meanwhile, you know that strengthening my core, you know this. Until now, the medical doctor give the prescription, please work on range of movement and core strength, right? So this is the advanced approach. And the sarcastic point that among the literature, we don't really know who is the core muscles, because it's prescribed differently from different authors. So who is actually the core? Okay? So then the step after, thought from the gap, even patients who are strong, they still have symptoms. It's not enough. So from here, the thoughts raise up from we just need not strength, but something to deal with stable muscles. So to have a healthy movement system, we need pain-free movement, mobile, we need full active range of motion, mobile. We need strength, but on the bottom foundation, we need stable, strong muscle. Stable and strong. And the stability is the element that it's the control. We need a muscle not just to be powerful, but to be controlled. And there is a major difference. You can find an athlete, CrossFit, as the one I see, heavy lifters, they lift, deadlift up to 130 kilos, very powerful, but he doesn't have efficient control, and I will explain myself later. But what I want to say, power is a function of muscle, control is another thing, and we need to work on both stability, strength. Does it make sense? Any questions so far before we go to the next point? All is good? So, talking about the authors of the kinetic control, before the term kinetic control is studied by Sarah Mottram and Mark Comerford, the motor control was a very broad term. Even before the motor control, we had gender approach, the muscle imbalance. Are you familiar with the muscle imbalance? Upper cross syndrome, lower cross syndrome. This is an approach by Yanda approach or Janda approach, who thought about like muscles against each other in region causing symptoms. It is okay, but it's not so accurate because it relies on what you see, and this is subjective. And then came Paul Hodges, that we are interestingly met in the last conference in Lahore. Paul Hodges is the creator of the motor control. Paul Hodges is an Australian guy who spent years from the 60s and 70s doing research about the deep multifidus and the back, transverse abdominis as core muscles, to see how it changes physiologically and functionally in these muscles, the deep stabilizers, these small local muscles, how their pathology or how their dysfunction is related to the back pain compared to the healthy subjects. And he spent years doing EMG studies on the deep multifidus and TRA to see how their function or dysfunction is related to back pain or healthy movement around the lumbopelvic. Are you getting this? So it's a very important to know this name and to search for it if you want to learn more about the concept. And then came Shirley Sarman. She is an American lady. Started to explore how the patellofemoral pain syndrome is like syndrome. It's a pain in different things or because of different things. Is it a joint? Is it mechanical, just mechanical pain? So she started to think that it's not just the source of pain is the patellofemoral joint. There is cause of the pain. So she started to think about something called the movement impairment. What is the patient doing repeatedly? How he walks, how he stands. What is the movement? What is the function the patient do right or wrong? And how the movement load on the tissues the patient complaining with today. So she started to think, zoom out about the problem, that it must not be about the knee pain, it's about something related to patient pattern of movement impairment that ended up with knee pain. So again, Shirley Sarman and movement impairment is two keys you need to understand more about how this concept developed. And finally, Sarah Mottram from UK, Mark Comerford, an Australian guy, 25 years back, actually more, since 2000, they shadow Shirley Sarman and they started to develop from motor impairment to uncontrolled movement. What is the difference? Exactly the same idea, but more structured into system of testing. So the different thing about the kinetic control is it's a rated system, study it and compare it by research. but we use a clinical side of it. Okay? Well done. So, started the structure, then going to strength. Strength is not enough. We need to look at the movement, the kinesiology, the kinesiopathology model, and not pathoanatomical model. This is a very important. Kinesiopathological model. We know kinesio is kinesiology, right? Movement. Movement, kinesiopathology. Movement led to pathology. And this is the model, the approach we as physios need to use in our practice. The other model of the MDs, the physical, the medicine doctor, pathoanatomical. They look so anatomical. They look into the structure that I need to inject. Pathoanatomical. They do special tests. I need to look for the tissue. And actually, for a mechanical pain patient who's coming to us, this concept of pathoanatomical, digging so deep about tissue, is not helping to the patient, because when the problem gets chronic, it's not a specific thing, but it's a movement, it's a way ending up with different sources of symptoms. So we have the source, the pathoanatomical, the source of the symptoms. We have the cause, which is the kinesiopathological model. Cause of the pain, source of the pain. Cause is movement leading to pain. Source is just the tissue saying ouch because of the cause. Are you okay with this point? So, if I asked you, based on your understanding so far, what is the healthy movement? What is the movement you decide it's a healthy and it's okay? Pain-free? Controlled? Strong muscles? Okay. So when you see person move, according to the kinetic control, and this is also unique thinking, that the healthy movement system is the movement that have choices. For example, if we look at this picture, how me or you or Osama tying his shoelace. Look at this. How these child are tying their shoelace. You will find one bending all the way through the lumbar spine. Like this. You guys hear me? Yes. So when I think I'm loud enough. So when I do the shoelace, doing this movement, where the flexion comes from? The lumbar spine, right? So when this patient sits like this, where the most of the flexion comes from? The hip, isn't it? Or like this, the head, right? So if I want to like pray, for example, I do like this. So where the movement flexion comes from? The thoracic. If like us, like we are slouch, what is the signal most flexion? What I want to say, it's all bending forward. It's a one task. But my movement system is able to do the same task with different choices. Does it make sense? A healthy movement system, have the leisure, have the blessing of choices. As a healthy movement, I am free to do it like this. I'm free to bend like this, or the lumbar spine like this, or just stop the lumbar spine and go waiter ball using my hip. Are you okay with the difference of the three options? Please, if anyone is confused, let's repeat, because it's very important to see the movement and relate which region and muscles doing this movement. So again, I bend through my hip. So I'm just like this and my back is one block. This is an option. I bend with posterior tilt leg, taking punch on my back and bend like this. Okay? my back and hip are nothing, straight, and so this is flexion from the thoracic. So if I want to take something, I can do this, and come close, I do this, okay? Or bend the hip and take this. Everyone is okay? So in the normal happy life, if I asked Osama, Ruqayya, to do flexion, please Ruqayya, do it now from thoracic. Please do it from lumbar. Please do it from the hip. In the normal happy scenario, healthy patient, he should be able to give me the full choices. Different participants doing the flexion. Okay? If one participant stepped back and I started every single time to bend from my hip, this is an uncontrolled movement. Because the participants or the task went out of control. It's only one choice, the hip. Lumbar spine is gone, thoracic spine is gone. And this is a major problem. Why? Because according to healthy movement, the patient lost the choices. The kinetic control mentioned it, or they termed it as LMC, or loss of movement choices. How they define the uncontrolled movement. That patient has single pattern, not many pattern, to do the same task. Only one pattern, like robot. And this is not normal, and this is not what the body is designed to do. And this is what Lou Mayuki studied in the patients with back pain, like in the praying position. And he actually find that the patients who have back pain in flexion, when we ask them to do this flexion, they only do it in one way. Whether it's through the lumbar or the hip, whatever. But every single time to do repeated flexion, it's only one region doing the flexion. Whether it's a lumbar hip, according to how the patient have it. Does it make sense? So what I want to say that the pain and symptoms is related to the uncontrolled movement. It's not simple. Because imagine if in my daily life, in my praying routine, in my carrying my baby, every single time I rely on the lumbar spine. If we are sitting, all our sitting, posterior pelvic tilt, and slouch from the lumbar spine. What do you think could be the results of this habit? Just give me heads up. If I told you that normally I bend this one time, this one time, this one time, so the task is distributed for 3 participants. What if only one participant doing the job? Mechanical overloading. Mechanical overloading, because if I all the time like this, like this, like this, hip is gone, thoracic spine is busy in restriction, so is not free to move. So only the lumbar spine. Push, push, push. Eventually, this will end up by disc, right lesion or disc protrusion because of unfreeing the road to the disc and then pushing on the nerve. Are you with me? So for my new colleagues or the new physios, we know that the flexion is opening the intervertebral gap or a space. And this is how the donut, the chocolate donut theory, that if you push on donut, if you push, the chocolate will go up, right? So this is the disc content. When you push on the disc by this flexion, the disc content swell and push on the nerve, right? So the patient, after years doing this habit, today coming with the MRI that we have disc injury. Really, the disc is there like 2 years ago, right? But patient started to complain when the body tries its best to survive. Okay? And this explains why the patients are really good and all of the nowhere, I bet, I can't straighten my back. Because their body is getting for this injuries years and years. Does it make sense? So for the patient, what happened? Nothing new. Yes, it's micro trauma. In every single day, you have this pattern of movement. So in short, healthy movement has variability, has options to do the same task. Healthy normal movement. Unhealthy movement, uncontrolled movement, the movement that you will see patient is not able to control moving at single joint. Are you okay so far? So the consequences and the relation of uncontrolled movement to symptoms, that losing of variability, overloading in just one joint, will end up by mechanical overloading on passive tissues. Whether these tissues are nerve, disc, facet, muscle trigger point, name it. All these names are just the details because it's like the end result. But how it started, loss of the choices, moving uncontrolled in a certain region. And this is the region. When the patient comes to me complaining, we go the whole way around. So the patient last comes with symptoms, but we start assessing the cause of the symptoms, the movement pattern. Okay? And we will talk about that, but this is an item. Anyone feels confused or having a question, wants to repeat? Okay? I claim myself as very analytical person, and in every course I attend, I'm so much asking and I'm annoying the whole group. But I love questions and I appreciate questions. So please, no matter how you think the question is basic or irrelevant, don't hesitate to raise it up. Okay? Question for you. We made an agreement. You don't ask, I ask. Fair in the square? Good. So now, are all our muscles the same? No, right? So is there a whiteboard I can use for illustration, or it's hard? Not possible? Okay, so I will stop here for technical handling, and that's a good chance for you also. I will give it as a thinking task. You can talk together, like in groups. It's okay. And start to brainstorm how the muscles are different. The classification of our muscles, skeletal muscles. Talk to each other, just try to give ideas, okay? Now, start. Time started. You have 2 minutes. Whatever the classification, I just want to know how they are classified. You hear me? Let's get back on track. Where we stopped, what is classification of the muscles? Anyone give me heads up and yeah? Usama, you want to make a start? Yes? Just have a seat, it's okay. It's easy. But
Basically, there are three types of muscles in our body, like global mobilizer, global stabilizer, and local stabilizer. The global mobilizer, the one which are working on the
so I will go step by step because we are a big group. So my colleague mentioned that Sri already mentioned local stabilizer, global mobilizer. But may I ask you what this classification is based on? Function. Okay. Do we have another classifications to classify the muscles? 1, 2, 3, like one by one. So the lady first, and I will get back to you. She raised her hand first. Fast twitch and the slow twitch. And here, our colleague, what's your good name? Your name? Okay, Ravita. Our colleague is talking about another way to classify the muscle, which is the neurophysiology. So neurophysiologically, we have slow twitch motor units, fast twitch motor units. To make a start, motor unit is muscle fiber connected to neural cell, as simple. Nervous cell coming from the central nervous system, giving order to muscle fiber to do action or contract or increase the tone. Okay? This is what is motor unit. So we have slow motor unit muscles. The muscle fibers with this neural cell and fiber relationship is slow. And this means these muscles are phasic or tonic. Tonic. Because the slow motor unit is the nerve going to the muscle fiber is short and is thick. So the nerve impulse from the brain go like this. Tone, slow tone. Okay? So again, neural cell connected to muscle fibers. This neural cell want to give order coming from the central nervous system to muscle fiber. But we have two designs to this nerve. One is slow, so the impulse is steady and slow. It doesn't give a lot of impulse, okay? Because the nerve it's thin and it's short, okay? So the muscle receives the impulse slowly and sustainably, okay? On the other side, we have another design of motor unit called the fast twitch motor unit. And this design for fast twitch, the brain give fast order, okay? So the muscle fibers connected to fast motor unit is phasic. They receive big order or massive impulse to contract, to produce power, and then fatigue. So we call the fast motor units or the fast twitch muscles phasic muscles. On and off, phases. Contract and switch off. Fatigue. Snickers. Okay? So contract and then switch off. This is opposite to group 1. What is the name of group 1? Remind me again. Slow twitch motor units. Tonic. They have tone. Impulse but continuous, although it's a slow and small amount. Okay? Are you curious this? This is for a reason. We have a miracle in our body that every fine detail is designed for a reason to help the purpose. So the purpose or the reason why slow twitch motor units or slow twitch muscles are designed as a slow motor units because their function needs to stay active. What do you think? If here we compare the muscle like deep multifidus, transabdominis, or even deep neck flexors, if I told you these muscles are tonic and they are deep anatomically, and this is another classification, anatomically tonic muscles, slow twitch muscles, most probably are deep. So the location, anatomy, together with the neurophysiology, why? Because they are designed to maintain joint alignment and keep posture. Makes sense, right? So these muscles are not designed to produce force, unlike the other group. What was the name of the group B? Fast twitch muscles. Phasic muscles. Phasic muscles like erectrospinal, okay? Paraspinal muscles or superficial back extensors are long muscles, superficial muscles anatomy-wise, okay? Superficial, long, big muscles. And most of them are two-joint muscles. Why? Because they are designed to produce big movement. They are designed for movement. That's why they are mobilizers. These are the muscles that do big movement. Since they are big muscles, take two joints. So when they are activated, they do power and force. How? Because they are designed as fast twitch motor unit. So the fast motor unit help it to do this action. And the location anatomy of this group, again, confirm why they need this position and this design. Does this make sense? Are you okay? So what we are talking about? We have three functional classification of the muscles, three main groups. Stabilizers. Stability is important, so we have two groups, local stability and global stability. And the third group is global mobilizer. Three functional classification. Local stabilizer, group A. Global stabilizer, group B. Global mobilizer, group C. All our muscle in the body is already studied and put in one group. Okay? That I'm giving example. Deep multifidus is local stabilizer. Why? Because the EMG study showed that this muscle is tonic. It gets activated and sustain activity. So it's tonic. Okay? So these factors put all together, anatomy of the muscle, neurophysiology of the muscle, and also histology of the muscle. So histology of the muscles is the third way to classify the muscle. Big pause. I'm waiting for them and waiting for you to digest this information, because if you get this demo, you have got the end of the day. We build on this discussion.